Hello and welcome to the Center for Medical Justice, where we delve into the latest scientific breakthroughs related to pain and addiction. Today we're exploring what could be a groundbreaking discovery in pain management that could revolutionize how we treat chronic pain. Let's dive in. First, some basic science. All pain is nothing more than the brain's interpretation of an electrochemical signal transmitted from the body. The brain itself has no pain receptors. Pain receptors in the peripheral tissues detect chemicals released after an injury. These sensors generate signals in peripheral nerves and transfer them on to the spinal cord. The nerves themselves can become compressed or injured in conditions like sciatica or trigeminal neuralgia, which are terrible conditions to have because a pain nerve, when compressed, can generate the maximum amount of pain possible for that area. When these nerves fire, they send that signal to the spinal cord where the nerve synapses with a second-order neuron. At this synapse, the signal can be modulated by interneurons. If the first-order neuron fires long enough, the second-order neuron can become sensitized and start firing on any stimulation. That is why people will develop conditions like hyperalgesia, where a minor pain stimulus generates a large pain signal, and allodynia, where even a gentle touch can generate a pain signal. Something similar can happen further up in the brain, where the second-order neuron synapses with the third-order neuron. These and other repeating circuits can develop in the central nervous system in a condition called centralized pain syndrome. All neural activity is the result of ions moving across cell membranes, depolarizing the membranes and creating a moving electric current. These ions move through ion channels that are made by the cell for this purpose. These ion channels open or close according to electrical signals, if they are voltage-gated, or from the binding of chemical messengers, if they are ligand-gated. There are also specific subtypes of ion channels, so that the cell's activity can be fine-tuned and responsive. An example of a pain-relieving medication working through ion channels is Lidocaine. Lidocaine is injected in emergency rooms so that we can sew up lacerations. This medication binds to and inactivates voltage-gated sodium channels, since these are important for peripheral pain-reporting nerves. These medications, like lidocaine and bupivacaine, can block pain for several hours. Researchers at the Pain Research Center at New York University College of Dentistry were very interested in calcium channels called Cav2.2. Cav2.2 are also called N-type calcium channels, and they play a crucial role in the transmission of pain signals in the central nervous system. If we could slow down or block these channels, we could reduce the ability of these second and third order neurons to produce pain signals. This would be incredibly important to most chronic pain sufferers. Drugs like gabapentin and pregabalin, Neurontin and Lyrica bind these receptors at the alpha-2 delta subunit of the Cav2.2 channel, reducing pain signal transmission. This class of medications is called gabapentinoids. Gabapentin is recommended as a first-line treatment for chronic neuropathic pain by various medical authorities. This is a general recommendation applicable to all neuropathic pain syndromes except for trigeminal neuralgia, where it may be used as a second or third-line agent. But while these medications are now widely used for nerve pain and epilepsy, as they are the best we have at this time, they are not without problems. Gabapentinoids, while therapeutic, also produce feelings of relaxation and, in some people, euphoria. And we tend to repeat activities that generate these feelings. With the increasing prescription rates of gabapentinoids, there's been a corresponding rise in its misuse, especially in combination with other medications. People subject to substance abuse issues may be drawn to gabapentinoids for their calming effects. If mixed with opioids, alcohol, or other depressants, gabapentinoids' effects can be amplified, leading to increased sedation and, in some cases, dangerous respiratory depression. Overdose-related deaths due to gabapentinoids themselves are still quite rare, but combination deaths are rising. Now, any medication or substance can kill you if you take enough of it or in the wrong combination. Simple medications like nitroglycerin that people with heart disease use for angina, and a medication like Cialis, used for erectile dysfunction in many of the same patients, when combined, will kill you. But much more common is the potential for the gabapentinoid's euphoric-producing effects which again only occur in a subset of patients, to produce a substance use disorder, even perhaps addiction. A substance use disorder can be considered a situation where someone chooses to use a substance or activity to alter their mood or experience euphoria despite negative life consequences. Addiction, on the other hand, should be considered a loss of control of the use of a substance or activity. These people cannot stop, even if they really want to. This loss of control is mediated by overexpression of the gene delta phos-B in the nucleus accumbens of the brain. The risk of gabapentin abuse highlights the need for careful prescription and monitoring practices. Healthcare providers are advised to screen patients for a personal or family history of substance abuse, especially to alcohol or sedatives, and for mood disorders like depression and anxiety, before prescribing gabapentinoids, as these patients can be particularly susceptible to misuse. All patients should also be educated about the risks of misuse, with regular follow-ups and monitoring. Understand, however, that just because a medication has drawbacks does not mean that politicians and government agents need to Monday morning quarterback a doctor's decision to use these medications, like they're doing right now with opioids. In fact, there is evidence that gabapentinoids can even be used in the treatment of alcohol and sedative addiction through something called medication-assisted therapy. This is where a doctor can take a substance that has a similar but milder effect than a drug of abuse and use that to help someone maintain control of their addiction. This is how medications like Suboxone work, hopefully tapering off the milder medication later, though some people need maintenance therapy to avoid relapse. Gabapentinoids have been an amazing medication for those suffering from nerve-related pain, but what if we could find a better way to produce this effect, perhaps without the potential for euphoria? There is a natural 17-amino acid molecule called CBD3 that specifically binds and deactivates the Cav2.2 calcium channel. What if we found a medication that worked like this natural molecule? In a report from a study published in the Proceedings of the National Academy of Sciences, it was announced that we may have a significant breakthrough in this pursuit. Researchers at New York University, in collaboration with colleagues at the University of Pittsburgh, ran a computer simulation that screened a library of 27 million compounds to look for a small molecule that would match the CBD3 amino acid's activity. The simulation narrowed the library down to 77 compounds, which the researchers experimentally tested to see if they lessened the amount of calcium influx. This further pared the pool down to 9 compounds, which were assessed using electrophysiology to measure decreases in electrical currents through the calcium channels. One compound, which the researchers named CBD3063, emerged as the most promising candidate for treating pain. Biochemical tests revealed that CBD3063, by disrupting the interaction between the Cav2.2 calcium channel and CRMP2 protein, had the greatest effect. CRMP stands for collapsin response mediator protein and is critical to neuroplasticity in these central pain nerves. CRMP2 can regulate the trafficking and surface expression of various ion channels and receptors, including Cav2.2 calcium channels. Reducing the rate of calcium entering these channels reduces the firing rate of central pain neurons, which lessens the release of neurotransmitters and may actually reduce the development of these circuits. This new compound was later proven effective at reversing 4 types of chronic pain in animal studies. What's remarkable is that it outperformed gabapentin itself, without any evidence so far of the troublesome side effects. This discovery is not just a scientific achievement. It's a beacon of hope for millions suffering from severe chronic pain. And it underscores the importance of innovative research in developing new pain therapies. Now please remember, this information is for scientific, educational, and journalistic purposes only and should not be considered medical advice. Medical treatments are complex and should always be discussed with your personal healthcare professional. Thank you and stay safe.